Should we shift all patients with HFrEF who are on ACE inhibitors to ARNI? And when do we switch? Should we wait till they become unstable? The point here is, are your heart failure patients really stable? That is a question we need to ask ourselves. When we know that the patients are not complying to medicines or the physicians are not giving the guideline directed medical treatment, there is a high chance that your heart failure patients could decline into hospitalizations for heart failure. They could have index again and again admissions for heart failure. So we should be very, very clear that what are the molecules we are going to start them on. Now, only 20% of stable patients, that means there are no prior heart failure hospitalization in Paradigm HF trial, had a primary event. 17% died during the course of the trial. Of the stable patients who experienced a primary event, death preceded the heart failure hospitalization in 51% of the patients. 60% of these deaths were sudden cardiac deaths. This is very important to understand. So the concept of stable heart failure does not exist, my dear friends. And ARNI should be started as early as possible for your patients. Convert them immediately if they are on a regular ARP or an ACE inhibitor, so that we don't wait till the deterioration occurs, because that deterioration may not be there. It just could present as an event of sudden cardiac death. Now, when you look at the 2022 AHA, the ACC, the Heart Failure Society guidelines for management of heart failure, the 1A recommendation is that in patients with heart failure with reduced ejection fraction and NYHA class 2 or 3 symptoms, the use of ARNI is recommended to reduce the morbidity and mortality. Also, 1A recommendation in patients with previous or current symptoms of chronic heart failure with reduced ejection fraction, the use of ACE inhibitors is beneficial to reduce the morbidity and mortality when the use of ARNI is not feasible. So in patients with previous or current symptoms of chronic heart failure with reduced ejection fraction who are intolerant to ACE inhibitors because of cough or angioedema, and when the use of ARNI is not feasible, the use of ARB is recommended to reduce morbidity and mortality. So only if there is severe contraindication for the use of ARNI, then only you should not use ARNI. Otherwise, in all your patients, which will come to around 98 to 99% of your patient group with heart failure, please do use ARNI. There is no option available. Now, how early can we start ARNI in acute decompensated heart failure? Do we start it before discharge or during the first follow-up? And what are the precautions you need to take? The Pioneer HS trial, the study designed was that they examined 881 patients who were hospitalized for acute decompensated heart failure with ejection fraction less than 40%. The patients were stabilized while still hospitalized. The systolic blood pressure was more than 100 within the 6 hours, no increase in IV diuretics prior 6 hours, no IV vasodilators in the prior 6 hours, and no IV inotropes in prior 24 hours. This is very, very important. So when we are starting a patient of ARNI, it should be justified that when you are comparing an ACE inhibitor or an ARNI, there is no doubt that you need to start ARNI. But when do you start it is the question for acute decompensated heart failure. So this recommendation is very important. So if a patient has a systolic blood pressure which is approximately around, according to me, even 90-100 is fair enough. A patient who has stopped his inotropic support in the last 24 hours, not receiving any IV diuretic therapy, and also that the patient should not be on vasodilators in the last 6 hours. So these are the time when you should start initiating your ARNI, and this should be done prior to discharge. Why is that? The studies have found that there is a change in the NT-proBNP not within like a week or 2 weeks, but within the first 8 weeks after randomization. So when you have a patient just on an ACE inhibitor of enalapril, and as you compare it to an ARNI, you'll find that there is a dramatic change in the NT-proBNP over a period of 8 weeks from the baseline initiation, and this starts within the first week. So the benefits of starting ARNI should be taken as early as possible prior to the discharge. And also the second point, the cardiovascular death and rehospitalization for heart failure, the benefit starts immediately within the first week, as you see after randomization, and you'll see that the graphs completely vary and they diverge. The benefits are definitely weighed towards ARNI as compared to ACE inhibitors. So there is no doubt in my mind that can we start ARNI in a de novo hospitalization, a hospitalized patient with heart failure? Yes, you need to start ARNI before the patient gets discharged. But remember 4 points. One is, see that the systolic blood pressure is 90 to 100. Inotropes are stopped within 24 hours. That means don't start an ARNI within 24 hours of starting the inotrope. Give it a gap. No IV diuretics 6 hours and no vasodilators within 6 hours. These are the 4 points which we need to understand.